Hey there! So this is a really stressful time with the coronavirus. I wanted to share some information of what we know so far for coronavirus as it relates to being a new nurse practitioner or nurse practitioner in general, quite honestly, in primary care in the outpatient setting. Background information, the facts of what we know, what's evolving, and what we can do to help reduce the spread and to care for patients with coronavirus. And so if you're new here, I'm Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. So I'm just going to jump right in. I have my notes down below so I don't miss anything, so that's why I'm looking down. Everything I'm talking about so far is what we have for the evidence, and that's coming from CDC guidelines, because I'm in the United States, World Health Organization, as well as the studies and the case reports that we have so far, because it's all brand new stuff, and so that's what it's all based on. So I just want to start by saying coronavirus, everyone's talking about. COVID-19 is the other name for it, and it's actually also called SARS-CoV-2, which you probably heard, but everyone's talking about coronavirus. And I just want to be clear that coronavirus is a family of viruses. So MERS, the Middle Eastern Respiratory Syndrome, I believe that's what the S stands for, SARS as well, those are all in that coronavirus family. So I had a question recently of, can I test for coronavirus using that upper respiratory virus panel? And as of the recording today of March 21st, 2020, the only available testing that we have is through the Department of Public Health and the CDC. However, they're working on commercial testing to be available, hopefully very soon. So the labs that you have in your traditional labs that you've tested for before, when they're talking about coronavirus, those labs are talking about, that respiratory panel is talking about those other coronaviruses. So just saying that for the start. So, but that's something that's upcoming, at least in the United States. So, but this is a novel virus. We don't have any immunity to it because we've never been exposed to it before, and it's moving really rapidly and throughout the United States. So there's a question about droplet versus aerosolized spread. So what kind of precautions you need. So this virus is spread through droplets, meaning like when like coughing within the 3 to 6 feet. However, there were studies looking at the virus, and this is actually in the New England Journal of Medicine, if you're interested in reading more about it, testing about how the virus itself is transmitted. So there are aerosolizing procedures, meaning intubation, mechanical ventilation, CPAP, BiPAP, endoscopy, bronchoscopy, CPR, things like that. Those will aerosolize the virus, and those need airborne precautions. There's actually also a question about using nebulizers, and there is some evidence that nebulizers can aerosolize the virus, although I found a little bit of conflicting data about that. But to be safe, as of right now, as of today, as of the recording, it's recommended to avoid those aerosolizing procedures in suspected or infected patients. So those procedures need an N95 respirator mask. Otherwise, in the community setting, but if you're directly caring for a patient with COVID-19, it's recommended to have droplet, contact, and standard precautions for a face mask with a shield over your eyes, doing some sort of eye protection as well. There is a shortage right now, I'm sorry to say, of protective equipment, and that is constantly evolving in terms of how we're getting more of that. And if you have other questions about that, definitely let me know. I have a number of links, actually, I'm going to link to below this video, so hopefully that will be helpful as well in terms of like where directly to go to CDC. As far as of today, the White House reporting on updates, there is talk of releasing more personal protective equipment. That should be coming out hopefully soon. I don't have any concrete data for that, unfortunately. But again, I'm going to link to down below this video, all those links to kind of look at. So the incubation period, so it's about 5 days. That's the average, but it can be between 2 and up to 14 days. Very, very few of the 14 days, but typically 4 to 5 days of incubation period in terms of transmission. The symptoms that patients have are kind of all over the place. However, there's a solid 3 that they typically have. And so this is based again on data of the patients that have had it so far. So it's a range of presentation from mild to severe, which I'll talk about in a second, but the symptoms are typically fever, a dry cough, dyspnea, and then fatigue/malaise. So those are the main ones. Fever being the most common one in terms of like 70 75 to 99% of patients, and kind of goes down from there in terms of the cough and going down. Some other symptoms that patients may have are less common: sore throat, headache, cough with sputum, hemoptysis, nausea, and diarrhea. I had a question about, is that the more predominant symptom right now? And to bring a little bit of levity to the conversation, I feel like a number of people are having nausea and diarrhea from the anxiety right now. And I'm not trying to make a joke, I'm just trying to make light. But as of right now, it is not it's not like the new predominant symptom as of this recording, as of the data that we have right now. An important note though, two important notes I want to make about the symptoms, is that fever is the most common symptom, but it may not present right away. So the patients may have COVID-19 and be infected, but they may have their fever not happen like right immediately in the next 24 to 48 hours approximately, that they may become febrile. They may become febrile right away. But that's definitely concerning, right? Something to think about. There's also a note of these patients can get worse. So actually, before I talk about worsening, I want to talk about the mild, moderate, and severe. So 81% of patients have mild illness, so about 81%. And those are all of those symptoms, but they self-resolve, they feel fine, they move on with their lives after it's over. It takes about 14 days to get better. There are severe and critical cases though. So severe illness is about 14% of patients. And what that means is they have hypoxia, dyspnea, and again, I'm looking down so I don't miss any of my notes, hypoxia, dyspnea, and then they can have 50% of lung involvement over the next 24 to 48 hours. And so, sorry, I should back up for a second and say that it's a respiratory virus that can cause a viral pneumonia. So what can happen is that on chest CT or x-ray, presumably as well, everyone's talking about CT, but presumably on x-ray as well, is that it causes bilateral ground glass opacities and consolidations. And again, in the severe cases, it can overtake about 50% of the patient's lungs. And so those patients, when it's severe, they typically need hospitalization. Critical illness, again, critical meaning ICU, supportive care, ventilator, all that stuff, they're going to need that kind of support. And I just want to pause here and say that you've probably heard about this flattening the curve and how we're going to get ahead of this virus. And this is the main sticking point to share with patients and understand yourself, is that there's mortality rate is about 1% overall. For patients who don't have any, it's about 1 to 3%-ish. It's kind of like varied, right? But for patients who have no comorbidities, the mortality rate is about 1%. The flattening the curve concept that everyone's talking about is that if we have a surge in cases that are very high, it's going to overtake the healthcare system such that the patients who are in that 14% of severe illness and then the 5% of critical, we won't necessarily have the medical resources and support to care for those patients. So if we had everything operating as normal, we could save all of those people. The risk is that we might not have the resources to do so. So this is the number one sticking point, I think, in terms of patient education. Just pausing here to talk about that because a lot of people are talking about we're overblowing this, we're not taking it, patients aren't taking it seriously, or they think that we're making too big of a deal out of it. I think that will change in the coming days, to be quite honest, because of how rapidly things are changing, especially in New York City. But yeah, so I think that's the sticking point, because I mean 14% is really high. 14 out of 100 people is if they don't have the resources that they need. And there's actually a pretty sobering article, which I'll also share below, which is looking at epidemiologic data in terms of looking at where we are right now and where we could be going. There's predicted about 2.2 million deaths. However, again, due to shortages of healthcare, could be up to 4 million people dying in the next couple of months. And so I'll link to that down below. That's epidemiologic data. That's kind of forecasting. But anyway, not to get too somber, but those are really important facts, I think, to have for yourself in your arsenal, as well as for patient education. I'm very honest with patients, and you don't necessarily need to give fancy numbers or anything like that, but if you can kind of just paint the picture of what this actually means and how they can help themselves and help the people that they love by social distancing and all the things that we've talked about so far, at least in the general sense. So I just want to go back to symptoms for a second. So when it comes to severe cases, there's kind of like two pictures of that. And so one is that, again, 50% of a patient's lung volume could be overtaken by this virus in the first 24 to 48 hours. However, there is some data that around day 7 to 9, there's a worsening. And so patients, if they have mild symptoms at first, thinking about how are they going to do in the next week or so, at that time is typically when you see a worsening, when they've seen worsening so far in this illness. So again, fever, dry cough, and dyspnea are the main symptoms. Most of them are mild, but the ones that are severe and critical tend to either have an acute worsening right away or in about 7 to 9 days, and then they need to go to the hospital. So who's at risk? So the patients who are at risk, you know this probably, but I just wanted to give you some data here. So based on what we understand so far, older adults are at risk. So it increases every age after 60. So if the overall mortality rate is about 1%, 1 out of 100 people will die from this without comorbidities. The patients who are older adults in their 60s is about 3.6%. Getting into your 70s is about 8%, and then over 80 is about 14.8% mortality rate. So it's pretty scary. So for patients with comorbidities, they are also at higher risk in terms of the data that we have. So 10.5% for cardiovascular disease. That's pretty scary. So if you think about somebody, and it's hard to parse those out, right? If somebody has cardiovascular disease and they're over 80, like, does that increase the risk that much more? I mean, I'm not that savvy with all the epidemiological data and all that stuff. Things to think about are diabetes, hypertension, respiratory diseases, and cancer. Those are the ones specifically mentioned in the research that I found, and those were about 6 to 7% mortality rate. So those are the higher risk groups. I mean, you always think about patients who take immunosuppressants. There wasn't anything necessarily specifically said about that, but you just want to be mindful and taking precautions for those patients. So I wanted to address specific populations, and so there were questions about children and pregnant women. If there's anything of a bright spot in this pandemic, is that I'm trying to be positive, but so far in China, less than 2 to 6% of the people infected with COVID-19 were pediatrics. Under age of 20 rather. And then in China, at least, there were no, as of the data that I have available right now, there were no deaths under the age of 10. So it's, again, this is all evolving because it's limited data and it's based on what we're seeing so far. So that's as far as we understand so far. Typically they have a much milder illness, and I think this really concerns me in particular, is that they have things like fever, cough, congestion, rhinorrhea, and then case reports of vomiting and diarrhea. And like, how many pediatric patients do you see with that on an average day? So that really makes me a little bit unnerved. But overall, for their safety, it's makes me a little bit more optimistic for the kiddos, at least. So pregnant adults, there's a lot of concern about pregnant adults on the provider side and on the patient side. And again, limited data. We only have, as far as the data that I have, is that we have case reports of 18 pregnant patients and with 2 neonatal infections, but no known transmission in utero from the pregnant woman to the infant. And the infections were thought to be after birth from contacts in the environment. We will have to see how this virus affects people in the long term with early pregnancies now. For that, we just don't have any data. However, when thinking about pregnant adults, aside from the fetal concern about fetal transmission, which we don't know about right now, but as far as we can tell, it's not an issue. Pregnant patients in general are more susceptible to illnesses. Any viruses, SARS, MERS, influenza, they're just higher at risk for getting those more severe forms of the illness. And then another note about breast milk and breastfeeding for newborns, there is no virus been detected in breast milk. The only consideration to think about is if you have a mother, a pregnant postpartum adult who is breastfeeding, you want to have them wear a mask to prevent droplet precautions to the infant. So hopefully that's reassuring, but again, we just don't really have a lot of data. So I wanted to talk about treatments, and then I'll move on to talking about what we can do as primary care providers in the community as of right now. So treatments, there's been a lot of things circulating around, and I want to get rid of all of those rumors and just address the data that we have so far. So there's 2 antivirals that have been studied and are not shown to be effective. That's remdesivir and I'm not going to say it right. Lopinavir, ritonavir is a combination, and remdesivir. And so they were under investigation, but in the New England Journal of Medicine, the most recent study that came out did not show any effect. Hydroxychloroquine or chloroquine, that malaria lupus medication, Plaquenil, is another name that you might know it by. So in vitro inhibited the virus, right, in studies. But when it comes to actual patients, though, the data is really limited. So there was one study that came out recently of 36 patients, a very small open label, non-randomized clinical trial, and that was in France, I believe. And 20 patients were treated with hydroxychloroquine. Some were also treated with the azithromycin as well. And what they found was when they were measuring their viral burden and the duration of their illness, that it was slightly shorter in the patients who had the treatment versus not the treatment. There's a lot of concerns about this study. Number one, it's very small, and the control groups, in terms of like methodological concerns about like how well the study was set up, like how much we can actually extrapolate from this data. There's definitely a lot of information circulating around in the news, in terms of like, is this an effective treatment or not? And there's not real guidance right now, but in terms of what I personally am going to do is that I'm not going to be prescribing this for patients in the outpatient setting with mild illness. And I would recommend, well, you can take whatever you want from that. You don't have to listen to my advice, but I think that generally speaking, the general consensus right now is that we're reserving this treatment for critically ill patients until we have further guidance and further research and testing. And I also, in the back or maybe front of my mind is thinking about depleting the resources that we have for the critically ill patients, keeping in mind that the mild illnesses will self-resolve. I just want to talk about a couple other meds. There are some other medications that are being investigated in clinical trials. An IL-6 inhibitor, I'm not going to say the name right. I'll link to this below, but there's a little bit of controversy over steroids, glucocorticoids, and so the thought before was that we don't want to use steroids unless they have an underlying reason to, right? They have a COPD flare and you're concerned about coronavirus. There is some thought now that the critically ill patients may be benefiting from corticosteroids. So overall, though, in our setting, it's not recommended to do that for patients. There were also questions about NSAIDs and ACE inhibitors and ARBs, and that there was a concern for worsening. And as of right now, there was some anecdotal concern about patients who were getting NSAIDs instead of Tylenol, worsening their symptoms. There's nothing right now. So just if you're concerned about it, you could recommend Tylenol instead. ACE and ARBs, there's something about on the very small level of the receptors for the virus and ACEs and ARBs and all that stuff. You can definitely look into it if you want to learn more about it, but it's been thought that it's not actually a concern. And if you took patients off of that, it could worsen their underlying health problems, which could worsen their outcomes with COVID-19. So that's the thought about that. So the other thing actually I wanted to say about corticosteroids is that there was a concern for other coronaviruses, again, MERS and SARS and all that we could be spreading the virus more with steroids. So there's no data for that for this virus, but that's the reason kind of why. Testing and treatment. This is tough, right? So we're in this sticky situation as of this recording, as of today, March 21st, 2020, that in the United States, we do not have ready access to the tests that we ideally would like to have. The World Health Organization is recommending to get an epidemic under control is to test, and to get patients isolated so that we can slow the spread of this. However, the concern is that we don't necessarily have commercial available testing. It's underway. They're working on releasing it. They're working on doing more tests and all that. But right now it's through the Department of Public Health and the CDC. There was a White House conference today that was recommending that we use priority testing and not necessarily test everybody, especially if they don't have symptoms, but prioritizing the higher risk patients, the critically ill, the hospitalized patients, the patients over 65 with the comorbidities, like all of those patients definitely should get testing. But I think the concern right now and where we are is that to protect people, we don't necessarily need a coronavirus test. So just stick with me for a second. Don't quote me out of context here. There's two pathways. One is that ideally we will move to the place where we have all the tests that we need. We can test everybody who has coronavirus. We can isolate them. We can isolate their contacts. We can get it under the control in the way that South Korea is doing or has done. There's an article in Science magazine talking about that. But then the other side of the story is that what we have right now, whether or not we have access to testing, the moral of the story is that most patients have mild illness. So if you're concerned about patients with coronavirus, the main treatment for them is just to self-isolate, to go home, take care of themselves, relax, make sure that they don't get worse. Again, keeping in mind that they could get worse around 7 to 9 days after the onset of symptoms, and that they are wearing a mask when they're around other people or they're out of doors, but like ideally they're staying at home, right? And it takes about 2 weeks to go away. And then hopefully things will continue to evolve and we'll have more access to the resources that we need. So who to test, the guidelines from the CDC is based on clinical judgment. So it depends, early on it was the Department of Public Health had guidelines for who to test and basing on their risk factors. So did they have direct contact with somebody with known confirmed COVID-19? Are they a healthcare worker working with suspected patients? Did they have recent travel to endemic countries? Those were kind of the main criteria, but it was based on the Department of Public Health that you were looking at. But I think it typically will come down to, as we get commercially available testing, does it fit criteria? Again, based on the symptoms: fever, shortness of breath, dyspnea, cough, dry cough. The test is a nasopharyngeal swab, and it will continue to be so. And there's some guidance from the CDC. If you do not have access to a nasopharyngeal swab, you can do an oral pharyngeal swab, meaning a throat swab. So yeah, so if the treatment is to stay at home and to self-isolate for treatment, it can end according to the CDC guidelines. And again, I'm looking down to make sure I don't tell you the wrong thing. So it depends if they're going to be tested or not going to be tested. So as of right now, it doesn't sound like we necessarily have the availability to retest patients. It really depends on your state. Department of Public Health, definitely reach out to them for further guidance, and your supervisor in your workplace, of course. But if they will not have a test to confirm that it's been eradicated, that it's gone, the criteria is three things. One is that they've had no fever for the last 72 hours without any fever suppressing medications like NSAIDs or acetaminophen. Two, that the other symptoms have improved, their cough or shortness of breath have improved, and it's been 7 days since the onset of their symptoms. They need all three of those things. This is all developing, but there is evidence that it's detectable in serum and stool, the COVID-19 virus, but according from the data that we have from China, fecal oral spread was not necessarily a concern. Something to keep in mind, because that can be detected in the stool for up to weeks, but that is the official guidance from CDC, is that patients self-isolate at home, keeping a mask on in their house and in their vehicle with other people. I mean, it's hard to prevent the spread inside of a home, but that's the ideal. And that once they have had no fever for 72 hours without any medications, it's been 7 days, and their symptoms are better, then they should be okay. But again, continue to stay up to date with CDC. I'm sure this will evolve as our knowledge evolves. So down below this video, I have a couple of different links, how to optimize the use of limited personal protective equipment, PPE, and face masks as directed by the CDC. The testing reports in the US and the number of cases updated daily. Again, there's a little bit of a lag for this. Other updates in testing, there were some news sources that were saying that there was a rapid tests approved by the FDA, but as of the time of this recording, I don't have any further confirmation about that, but hopefully that's coming soon. And a lot of other people have asked about ways you can help, and so the ways that I can see so far, number one is continuing to speak up in terms of, not to get political, but speak up in terms of there are various petitions going around and advocating for the resources, if there is a venue to do so, to communicate with your supervisor, your staff, and on that national level. Donating blood, there's definitely a question about, there have been canceled blood drives, or people who haven't been attending blood drives, and I think that there is a blood shortage right now, so that's something to consider. I don't know about the risks of the COVID-19 in the blood and all of that stuff, but as of right now, it's recommended to donate blood. I think the biggest way is really just communicating with patients, with family members, with friends, with people in your communities that you're seeing that are not following social distancing and not taking it seriously, to speak up and just to tell people about that, because the longer this is delayed, the longer it's going to go on. And I think, take really good care of yourself, because these are some tough times and it's really stressful, and I hope this was helpful in terms of getting the information that we have so far, and I'll definitely leave updates, anything that I have, down below this video. Another thing is that one of my friends, I'm Nurse Liz on YouTube, did a video recently about setting up telemedicine, and so I didn't talk about that in this video, but definitely go over there and check that out if you're trying to still set that up for your clinic, and hopefully they are supportive at your clinic and you're able to get the things that you need. If you have any other questions though, definitely let me know, and thank you so much for watching. Hang in there, and I'll see you soon.